So we're bringing together a dynamic duo to discuss issues that are specific to thyroid cancer survivors. So Dr. Erik Blomain is a radiation oncology resident who has dedicated his career to working with cancer patients after his own cancer journey, which he'll speak about. And Dr. Saad is a medical oncologist and expert in the treatment of aggressive thyroid malignancies. So thank you both for partnering up, particularly at such a last-minute time, and for talking to the team about this very important issue.
Thank you, Heather, and thank you for the organizers for organizing just some really fabulous talks today. And I've just been sitting in the audience just awed by how wonderful all of this work is. And I would second what Dr. Beadle said, that it's the patients that we learn the most of, and I think you'll find that that is the theme of my talk as well. We're going to be tag teaming because at the last minute I found out that Dr. Blomain had suffered a cancer diagnosis and will share his details as well. But just to get started, I lead the endocrine research group at the Stanford Cancer Institute, and head and neck cancer and thyroid cancer share a lot of similarities. So much of what you heard this afternoon about survivorship in head and neck cancer also applies to thyroid cancer. However, there are some distinct differences, most stark of which is that of the roughly 40 to 50,000 people that are diagnosed every year in the US with thyroid cancer, 98% die of something else other than thyroid cancer. Now, that's still not perfect, but it is much better than you see with our success rates and survivals with head and neck cancer, where almost 13 to 15,000 people die every year. So we're dealing with a lot of thyroid cancer survivors, and we're going to hear from two of them directly. And today, what I'm planning to do is just synthesize some of that information that is specific for thyroid cancer that we heard from the psycho-oncologist, the oral care, and imaging, and see how that connects with the specifics of applying survivorship science to thyroid cancer. And a lot of this is going to be taken from very specific guidelines. So you heard from the NCCN guidelines, which is what a lot of us use for head and neck squamous cell cancer. In thyroid cancer, you have the American Thyroid Association survivorship guidelines. And they have very specific recommendations as well as definitions for what cure means, what surveillance recommendations are advised. And it starts off with a definition of what cure is in thyroid cancer. And thyroid cancer is unique in that a lot of patients who undergo a thyroid cancer surgery have their entire thyroid removed. And that does a couple of things. The thyroid is unique in that it is the only organ in your body that absorbs iodine. That's why we all have iodide salt, so that it can help with our thyroid our thyroid health. And then the other part that is unique is that it produces a protein called thyroglobulin. Now, no other part of your body should produce thyroglobulin, so if your thyroid cancer is entirely removed and there is no more thyroid tissue left behind, you will have no iodine uptake in your body, and you will also have no thyroglobulin produced in your body. At least that's the theory. And so when we define cure by the American Thyroid Association, they start out, of course, with saying that when you have no clinical evidence of thyroid cancer, that's the first thing that suggests that you are cured. There is no imaging evidence of uptake of iodine anywhere throughout your body, again, suggesting that there is no thyroid cancer remaining. And then third, that your body produces no thyroglobulin that is detectable in your blood. Because if you have thyroglobulin that is a tumor marker and that is released in your blood and is detectable, then that means that there is some thyroid cancer hiding inside there somewhere that may just be waiting to come back and grow. And your body can produce antibodies to this particular thyroglobulin protein. They're called anti-thyroglobulin antibodies, and they obscure our measurements, and they're used and incorporated into this. And of course, as has been the theme from all this morning, everything that we're hearing about survivorship all hinges on the great communication and relationship between the patient who has suffered so much and the doctor who is really there. And I'm going to let you guys in on a secret. These are the survivorship visits for thyroid cancer are really the highlight of my day in clinic. So I see 20 to 30 patients every day. Almost all of them are getting chemo, radiation. They're having the worst time of their lives. And then interspersed amongst all of this are people who come in and say, you know what, I'm having some bad days, but there are times when I forget that I have cancer. And that is the best thing that you can ever say to your medical oncologist or any oncologist, that, oh yeah, I was driving past Sand Hill Road and I remembered a few years ago that I had cancer. That actually does happen. I hope it happens to all of you eventually if it isn't already happening. And as we mentioned, the communication happens mostly through regular clinic visits. And I cannot emphasize what Dr. Beadle mentioned before about how important this clinic visits are to survivorship. Because that is where we get to form open lines of communication with the patients that we have formed such great bonds with. So during your intensive treatment phase, we are seeing you every week, we're seeing you more regularly. All of those things happen both in thyroid cancer and in head and neck cancer. And afterwards, patients have said that, oh, this is like an OB visit. For like the first 9 months, we were meeting very regularly, and now you just sent me off. But we still want to see you every 3 to 6 months, and then perhaps less frequently afterwards. The reason for that is that we want to listen to you, hear what your symptoms are, and then we also want to maintain open lines of communication so that if you do feel that lump in your neck, that swallowing difficulty, that change in your voice, that we are hearing about it. And again, in thyroid cancer, which tends to affect some younger people than head and neck cancer does, the priorities will change throughout this very decades-long survivorship period. So a patient that at age 18 just wanted to make it through college and survive really well may want to find out about fertility. How does that impact their ability to have children in the future? And again, the secret that I will tell you is that the moment we walk out of that room where you tell us that you're doing great and you have no symptoms and your kids are doing great and you're out going on vacation, we're jumping for joy. Like, your oncologists are celebrating. We are the happiest people in the world, and this is a bi-directional relationship. So you may think that you are getting something from us, but in fact, we actually learn so much from you about how to live our lives in a better way. And then not only the philosophical aspects of things, it's the scientific aspect of things. And that's why we spend so much time listening to you, and because we're seeing you every 3 to 6 months, there is no shortchanging on that clinic visit. We are making sure that we're listening to everything that we're saying, that you guys are telling us, and we don't miss any of it. That actually leads not only to improvements in the way that we lead our lives, but also the science. Now, of course, Stanford is a world leader in research. So, for example, one of my colleagues here, Dr. Lee, who I'm sure all of you know, has developed a research program based on one of the most common problems that patients with thyroid cancer and head and neck cancer face, which is the dry mouth. And so are there approaches that we can develop, chemicals that we can use that will reduce the amount of dry mouth that you're having, and then potentially even injecting stem cells into saliva glands to see if you can end up with producing a more functioning saliva gland and reduce the dry mouth that many patients with head, neck, and thyroid cancer suffer from. And again, we only get this because we listen to you, because you tell us what your problems are, and it tells us this is what we need to focus on. The next part of survivorship includes lab tests for thyroid cancer. And here, there is quite a big distinction between head and neck squamous cell cancer and thyroid cancer. And when I am in clinic and I see a patient with thyroid cancer, there are basically 3 groups of tests that come to mind. The ones that I routinely should never be ordering. So obviously, when someone comes in and they have new symptoms, all of that goes out the door. They're new tests that I will order based on what you tell me. But if you're coming in telling me everything is great, doing routine blood counts, blood chemistries, looking at your liver function, your minerals in your blood, your kidney function, liver function, all of that is actually not going to help you, and often will result in much more harm than actual benefit. Because as you heard, you can have tests that lead to unintended consequences and have no proven benefit in improving your life. So that's the first group of tests, which I know I'm definitely not ordering for my thyroid cancer survivors. And the second group of tests are the things that I almost certainly am going to be ordering. And that's a very short list. And that's your thyroid function. Now, if you have had part of or all of your thyroid removed, you're left with an inability to produce thyroid hormone, which basically sets the thermostat of your entire body. And so if you are taking thyroid hormone replacement, over time, as your weight fluctuates, as your age fluctuates, your body's requirement for thyroid hormone is drastically reduced or maybe increased. And so the TSH is something that is tested roughly every 3 to 6 months for people who are in my survivor clinic and coming in to be checked for it, their routine checkups. And the third is a third group of tests are thyroglobulin and thyroglobulin antibodies. And these are much more in the gray area. Now again, if you have a completely undetected thyroglobulin, you almost certainly are cured of your thyroid cancer. The issue would be, how long do I keep checking? And especially if 98% of people with thyroid cancer are going to die from something else, 10 years, 20 years, 30 years, I'm not sure I have an answer for that. But it does take into account the level of anxiety that people feel with tests and the level of reassurance that they want with tests and the level of risk that I determined at the time of surgery or at the time of pathologic evaluation that they need to have more frequent testing, especially during that initial period. And again, the difference with thyroid cancer is most thyroid cancer is well differentiated and it tends to grow very slowly. So even if you make it past that 2-year period where there is a high risk of recurrence of head and neck squamous cell cancer, there is still potentially a risk of the thyroid cancer coming back potentially years, if not decades later. And so that's where there's still a lot of uncertainty, and even the ATA guidelines say that these tests are risk stratified, but they are indeed personalized to what we deal with. And here, just for the technical aspect of things, some patients with thyroid cancer only have part of their thyroid removed. So you would still have tissue that takes up iodine on imaging. You would still have tissue that produces thyroglobulin. And the guidelines in those situations, and my practice in these situations, is that the level of thyroglobulin produced by the residual thyroid is still pretty predictable. And you can still check thyroglobulin and thyroglobulin antibodies on patients who still have some normal thyroid tissue. As long as you see it changing, that is a cause for perhaps further investigation. And here, this is where the blood tests of the future may change everything that we just talked about. Now, our colleagues who treat lung cancer have done something really remarkable, which is take tumor samples and analyze their DNA. So lung cancer has a lot of very specific DNA abnormalities, and the technology behind all of this is spectacular. That tumor samples that are taken out of someone's body can be analyzed for the presence of mutations or other DNA abnormalities. And when you search someone's blood, you take roughly about 3 or 4 tablespoons of blood out, and you can actually find the same DNA abnormalities in the blood as you do in the cancer itself. And these are literally just a few molecules of DNA that are being found. And whether this will, in the next 5 or 10 years, be used as a way of determining when people are at risk of the cancer coming back, which it currently appears to be headed in that direction towards lung cancer, or whether this would be used to detect cancer before it even is clinically apparent, it's unclear. And there has been a lot of false starts in this, but right now it really does seem like the moment for circulating tumor DNA, which is the technical term for this. So it's free DNA floating in the blood of patients who either have no cancer or have previously been diagnosed with cancer, may take the place of protein testing like thyroglobulin and thyroglobulin antibodies. And then the final part is imaging. And much of this we already covered during the head and neck survivorship section. Scanxiety is a real thing. And again, this is also very personalized to patients. There are some of my patients who feel reassured that they've had ultrasounds done, whereas almost everyone is saying how stressed they were waiting for the results. And now we have this new system where the results may have been finalized and then are released out to the patient before you've even had a chance to discuss them with the doctor. So they have all of this horrifying, scary terminology. And you know what? No one's talked to you about it. It just pops up on your MyHealth application. And so that is yet another layer that we have to incorporate and worry about. And the other part in thyroid cancer that is very confusing for many people is that you may come in with an enlarged mass in your neck, and we still say, you know what, we probably don't need to do more than ultrasound it or come back in 6 weeks, because a lot of these lymph nodes can be enlarged, whether it's due to fire season or your toddler has a sickness or something. Those lymph nodes and sore throats often happen. So again, putting it in the bucket of things that we definitely do for our thyroid cancer patient survivors, which is a repeat ultrasound to get a lay of the land. This is what normal thyroid cancer, this is what your normal neck after someone has been treated with thyroid cancer looks like. Things that we definitely don't do, which is routine CT scans, PET scans, iodine scans. All of those have no proven benefit and no role in thyroid cancer. And then the uncertain gray part, which is ultrasounds. Now, ultrasounds are unique in that not only are they relatively unpredictable, they're operator dependent. So someone may do an ultrasound and you're not really sure that you're getting exactly the same thing as someone before you did. But they're also unique in that they usually cause much less harm than CT scans, which come with a lot of radiation and other side effects. But all of the cascading problems that imaging causes are real. And this is going to become even more of an issue as technology takes this imaging to the next level. Now, some of you may be familiar with these handheld ultrasounds. This is a particular model called a Butterfly. And what's unique about it is that it's about the size of this microphone, even smaller. And it connects directly to your smartphone. And you are able to connect it to your neck and get imaging of your lymph nodes, any residual thyroid, any nodules that you have, and with minimal amounts of training or potentially even artificial intelligence, you may be able to identify changes in your neck on a daily, weekly, whatever basis. This image on the right side is from a YouTube video, which gives people tutorials on how to do ultrasounds of their neck. They're not that hard. But the problem is, if you start doing them, what is that going to lead to? Are we going to end up biopsying everything in your neck every time? Are you going to have more anxiety rather than less anxiety? But I think we as doctors need to start having this discussion with our patients about this technology is going to be out there. It costs maybe about $300 or something. And someone could easily do their own ultrasounds every few weeks and say, you know what, I feel reassured, or end up causing a whole new can of worms being opened where they come in and say, I saw something on my own ultrasound that showed an abnormality. And the best example of how this is a problem comes from South Korea. So in the early 2000s, they started doing screening ultrasounds for thyroid cancer on pretty much everybody who went to their regular annual wellness checkup. And what ended up happening is that they started skyrocketing cases of thyroidectomies, so patients getting their thyroids removed for thyroid cancers that were either non-existent and were falsely picked up by ultrasounds, or were so small that within the lifespan of these people, it would not have had any impact at all. And then again, that is a unique thing about thyroid cancer, that even if you do have this thyroid cancer in your neck, you're likely to not die from it. And as a result, mortality from thyroid cancer remained absolutely unchanged in all of South Korea. But the number of people undergoing major thyroid surgeries was drastically increased. And I think as these handheld ultrasounds and their associated trainings and artificial intelligence, machine learning becomes more prevalent, it would be wise of us to remember the experience of those programs that were held in South Korea. And I'm going to end here because while I was preparing this talk, I learned that Dr. Blomain had an experience with thyroid cancer, and I think it is essential that we hear from him. So I'm going to pass it off to him. Thank you.
Thank you. I'm going to just, thanks. Thank you, guys. I'm going to transition and go kind of play on what you kind of ended with, which is the need for communication as we kind of follow patients into the future and in light of these new technologies. So, my perspective is we have a patient experience talk to follow this. So I'm going to try to instead focus more on the doctor-patient relationship and kind of my unique perspective on that as both a doctor and a patient. So hopefully it's timely and meaningful. Again, I'm not going to dwell too much on my cancer story, but except to note the embarrassing photo from that time in my life that I found and decided to include for you. I just felt some flu-like symptoms, but I went to school in upstate New York in the winter, so everyone kind of went through that. And eventually, though, I ended up needing surgery, radioiodine, and then took the MCAT a few weeks later. It was kind of a whirlwind of a semester, but I was able to graduate on time and kind of, in retrospect, maybe should have taken more time to process, but I trucked on through and got through. And recently marked 12 years cancer-free. But then as I went through medical school, I started to realize that I wanted to spend my life helping cancer patients. But then this is kind of back to what I said is the focus of my talk today, that I realized that I had kind of a unique perspective as a doctor in training, but also as a cancer survivor. And I try to channel that into my clinical work. But I started then volunteering with THYCA, which is an organization that many of you may be familiar with already. And when I say volunteering, it was more like participating in support groups, both as someone trying to give support, but also to receive it, because these things go in both directions. And so I kind of realized then that through this different type of communication that I wanted to kind of, in addition to the clinical medicine that I'd always kind of dreamed about doing, I wanted to do more patient advocacy type work in the doctor-patient communication in that context. And so that's kind of where I'm going to focus today, because, I ended up being appointed to be a patient advocate on the NCCN Guidelines Committee for thyroid cancer, which sounds great, except at that point, I found myself asking, so what is patient advocacy? And so if you're going to be in the role I just mentioned, it'd probably be a good idea if you gave it some thought to kind of figure that out. So that was kind of where I started. You start up looking things in the dictionary. In terms of the NCI actually has a definition. And, you can look, Wikipedia has a definition. So I kind of tried to process and collate all these different definitions and find one that I found to be personally meaningful. And so what I kind of arrived at as my working definition was, it's someone who endeavors to ensure that the needs of patients are being met and that their unique voice and perspective are heard in matters that affect them. And all that is to say, it's a form of communication. So again, this is kind of like a running theme of this entire day, really, but definitely the last couple talks. And you'll see that can take many forms. That could be as simple as advocating in a one-on-one interaction with someone's patient, or a patient advocating for themselves to their physician, but it could also be on almost a societal or governmental level, advocating for cancer patients en masse. And so just I became immediately struck by kind of the complexity of a lot of these issues. And so this is a slide that was made by Jill Feldman. She's a well-known cancer advocate. I'm using it with permission. But she was told, she developed this slide as a teaching tool for like the complicated lives of cancer survivors. And she was told by a reviewer that the slide's too complicated. And she was like, well, duh, that's the point. Like there's a lot going on. And it's something that we as clinicians can sometimes miss, that, we see people one day every, 3-6 months, but, there's the other 99.9% of their lives that are going on in the background. And so, this is not meant in any way that we should be digesting this during the talk, but more just as a kind of a teaching point. And again, there's different levels of patient advocacy. I think, again, there's these micro level, which I view in my professional life as the doctor-patient relationship. How can I advocate for the person in the room with me? But then kind of a more activism meaning, and these are all kind of different manifestations of the need to communicate. I have a couple little cartoons that are kind of meant to highlight maybe some challenges in this. Like we talk about patient-centered care, but this patient's in the middle, but not really patient-centered care. These are mostly just kind of meant to be a half facetious look at it, but they're all kind of a little bit of a pun, chuckle-worthy in their own rights. But and then, sometimes we can't communicate because there's this jargon gap. It's very difficult, even with, whether you have decades of experience doing this, sometimes it's hard to communicate. So if someone comes in with very different levels of experience, it's hard. And so there's lots of barriers to communication. So to kind of summarize, you've got this ideal version in your mind that you learn in school about what the doctor-patient relationship should be, but then there are some challenges. From the patient side, communicating with their doctor, and this is something I've experienced from that side of the relationship. There's fear. There's, again, this like understanding gap. There's financial stressors and financial toxicity. There's family dynamics. And then there's kind of the desire to be heard and understood. But then the person on the other side is feeling a lot of kind of apprehension and fear about certain things as well, including fear of failing the patient. Am I good enough to treat the patient? And then they're also struggling to impart some of this very complicated knowledge that can be difficult. And then, there's lots of demands on time that cause burnout. And all kinds of things. So there's, ideally you'd want to break down that barrier. And so these are just some ways that I've kind of worked on in my own life to, kind of, in some ways almost give into it, like take a breath, just say, okay, it's like, be vulnerable. It's okay. Like, no one, I don't think even as a patient, I never expected my doctor to be perfect in that sense. They're a human being. So, acknowledging that from the other side has been important for me. And then as from the patient side, it's like, be as specific as possible as what you want and what your concerns are regarding the treatment. And then it's totally reasonable to expect your physician to address those concerns. And then, be assertive, but then also be ready to listen and learn. And I think, that can be challenging too, because sometimes it's like we all have our own ideas of what we want. But always when in doubt, share and communicate. And then kind of from the other side, I say I don't know all the time. I think there's a kind of this stigma that doctors don't like to say they don't know. And maybe that's true for some people, but it's definitely not true for me. And there's a mountain of things I don't know. Dr. Beadle can probably tell you that. But yeah, and then I find like noticing what is left unsaid is big. Like, why is someone asking that question? Or what's actually kind of driving the root of those concerns? And there are lots of people that get there without having been a patient, that they can get there and be really good at that. But that, if there's one intuitive sense that I think has been different for me before and after the experience, it's kind of that, just kind of that understanding of like being able to put myself in that position. So then I mentioned that's kind of like the small scale advocacy of like how you can apply it to someone in the room with you or like and foster a doctor-patient relationship. But then there's also, like I mentioned, like activism, advocacy on a larger scale. And I'm going to go a little quickly through this because I think we're already over time. But this is just an example of something that came up on the NCCN panel on which that I mentioned that I was serving, and that there's two forms of brain radiation that we give for patients with brain metastases. And typically, wherever possible, we want to target just the tumor, which is the kind of picture on the right there, versus treating the entire brain, which has more side effects, and like neurocognitive side effects. But long story short, there was a discrepancy in the guidelines for anaplastic patients, specifically patients with anaplastic thyroid cancer, where only the whole brain radiation was supported in the guidelines, and there wasn't really a clear reason for that. That why they would only be allowed this kind of more toxic treatment. So just as an example, that's kind of something that I took on as wanting to change and increase access of like equal access when there's data to kind of support that, which in this case there was. And then if there's not like clear data, then to generate it ourselves. So there were several trials that would have included those patients, so there wasn't a clear reason to exclude them, but there wasn't actually actual data in that population to support its use. So it's kind of like there wasn't a reason not to do it, but there wasn't necessarily a reason to do it. And so that led to kind of this cool crosstalk in my professional life where then the patient advocacy led to like a research passion, and I actually looked at our Stanford experience because turns out we've given this treatment to patients with anaplastic cancer, and then looking in a national database and showing that the results are pretty comparable to what we'd expect, and kind of moving the guidelines in that way. That was a really meaningful kind of holistic experience that kind of sums up my entire experience with cancer, I think. Having experience as a patient, advocating for patients, finding kind of a barrier to that, and then using those professional skills then to drive that advocacy. So that's kind of like my holistic experience so far, if I had to kind of sum it up in one example. So I'll just conclude and just say that doctors and patients each have unique perspective, but it requires a combined approach and communication. And so in my life, I've found that patient advocacy works to achieve it through communication, but also, again, through kind of more societal lobbying. I will say, just as a message to the survivors and the caregivers in the room, that your voice matters in your care, and you should always feel that way. And if you take one thing away from it, it's that. And so the system should rise to kind of communicate with you. I kind of was talking about a bi-directional approach, but at the end of the day, it's our job to kind of communicate with you. But yeah, I would empower you that your voice matters in your care and make sure it gets heard. So yeah, I'm looking forward to taking questions and having some panel experience. I think after this is a panel, and so I'm looking forward to I've already met some of you in breakout sessions, but maybe hearing more about all of your experiences. I'd just like to end with some like pop culture cancer references that, some of them are, I would say, better than others. Like, I don't know that we all want to be Walter White, but I think more awareness of cancer is generally better. And so, yeah, I'd like to thank the organizers and everyone listed on this slide. And thank Dr. Khan for kind of being a tough act to follow. Thanks, guys.